Hey everyone, this is Spencer, PGY2 Oncology Pharmacy Resident, and for this clinical pro I'll be talking about the management of acute, chronic, and refractory immune-related adverse effects of immune checkpoint inhibitors. So here I have a list of abbreviations as well as the definitions of which I'll be referring to throughout the presentation. But first I wanted to get into the mechanism of action of immune checkpoint inhibitors to give us a better understanding of how immune checkpoint inhibitors can cause immune-related adverse effects. The first immune checkpoint inhibitor we have here is ipilimumab, or Yervoy, which was the first immune checkpoint inhibitor therapy approved, and it is a CTLA-4 inhibitor. So on the left here we have the normal T cell activation, so a T cell and its CD28 receptor binding with an antigen presenting cell and a B7 ligand. So when these two interact we have normal T cell activation. So what ipilimumab does is it comes in and binds to the CTLA-4 receptor so that there can be no interaction with it, and that the only interaction that can be had is between CD28 and B7, resulting in T cell activation. So what you can think of this is that CTLA-4 inhibitor ipilimumab is just going to prevent T cells from being shut off or upregulates the immune system. Next we have the programmed death protein 1 or PD-1 and programmed death ligand 1 PDL1 inhibitors. So for the PD-1 inhibitors we have pembrolizumab or Keytruda and nivolumab or Opdivo, and for the PDL1 inhibitors we have atezolizumab or Tecentriq, avelumab or Bavencio, and durvalumab or Imfinzi. Their mechanism of action is similar to CTLA-4 inhibitors, but for PD-1 or PDL1s we have the T cell and the tumor cell. So T cells have this PD-1 receptor, which is normally responsible for binding with normal healthy tissues, and when it's bound it tells the T cell that this is a normal tissue and to not attack it. Tumor cells have adopted this mechanism to go unnoticed, so now some tumor cells have this PDL1 ligand, which interacts with the T cell and tells the T cell that it is a normal tissue and not to invoke apoptosis or cell death or to attack it. So where the PD-1 inhibitors work is binding directly to the PD-1 receptor, and where PDL1s work is they actually bind to the ligand, which is on the tumor cell. So different binding sites, but the same mechanism. So a fun way to remember the mechanism of CTLA-4 inhibitors and PD-1 or PDL1 inhibitors is to sort of think of it as a game of hide and seek, where CTLA-4 inhibitors are going to increase the number of seekers, whereas PD-1 and PDL1s are going to prevent any good hiding places. So you're going to have more seekers, less good hiding, so it's going to be an easier game of hide and seek. Getting into the utility of immune checkpoint inhibitors, so since their first approvals, they have gained numerous indications in a wide variety of cancers. They continue to be studied in different settings and have gained first-line therapy as either monotherapy or in combination with cytotoxic chemotherapy in a wide variety of cancers. Due to the great response and benefit of immune checkpoint inhibitors, as well as them continue to be studied, we can expect them to remain heavily utilized and their use to potentially increase in the future. With the continued use of immune checkpoint inhibitors and potential increase in use in the future, it's important to recognize their potential side effects, most importantly, immune-related adverse events. As we discussed, immune-related adverse events can be due to the upregulation or the amount of active T cells in the body by CTLA-4 inhibitors, as well as PD-1 and PDL1 inhibitors preventing self-recognition between normal tissues and T cells. So the types of toxicity that we can see is going to mainly be dermatologic, so a new macropapular skin rash, as well as dysfunction in the endocrine system, most commonly hypo or hyperthyroidism. For gastrointestinal, we can see colitis, and for organ-specific, we can see most commonly hepatitis. There can also be hematologic, musculoskeletal, neurologic, and other organ-specific complications with immune checkpoint inhibitors. Here we can see the incidence of irAEs. So this was a pooling of data of 36 head-to-head phase 2 and phase 3 randomized trials. So broken down by specific agents, we can see the any grade reactions as well as more severe grade 3 or grade 4 events. As we can see here, ipilimumab has the greatest incidence of any grade or grade 3 or 4 irAEs, followed by pembro, nivolumab, and atezolizumab, and then again, most commonly going to be affecting the skin, GI, as well as pulmonary for pembrolizumab. This looks at the incidence of irAEs most commonly causing fatalities for ipilimumab or the CTLA-4 inhibitor. The most common irAE that causes fatality is colitis. And then for PD-L1 or PD-1 inhibitors, it would be pneumonitis. And then for combination of ipilimumab with a PD-1 inhibitor, we're going to see higher rates of colitis followed by myocarditis. Here is just a better graphic to review the incidence of all types of irAEs and the different agents. So the most common we can see is going to be in that dark blue color. So that's going to be the combination of nivolumab and ipilimumab. So combining two immune checkpoint inhibitors is going to give you your highest incidence of toxicity, which is expected. One unique thing about immune checkpoint inhibitor irAEs is that they do most commonly occur within the first 6 months of therapy, but there is a wide variability in that there have been reports of irAEs occurring up to 1 year after even discontinuation of therapy. So it's important to have the patient monitor for irAEs at any point during therapy and even after therapy is finished. And then here is a table with a breakdown of the different irAE organ system and the most common or median time to occurrence, the shortest time to occurrence being in the endocrine system. Getting into the principles of irAE management now. So the most important thing is going to be early recognition and prompt initiation of treatment. So having the patient monitor for the common irAEs associated with each of the medications. When they do present, it's going to be important to try to rule out other potential causes since they can look like other toxicities, and when they're used in combination with cytotoxic chemotherapy or targeted therapy, it's hard to tell if this is due to a second possible agent. The next important principle is to accurately grade the toxicities using the common terminology criteria for adverse events. The next important principle of accurately grading toxicities using the common terminology criteria for adverse events. This grading system is very useful as it gives the toxicity as well as the specifics on how severe and how to grade, and that correlates to what treatment to initiate. If able, it is recommended to consult organ-specific specialties. And lastly, to use published guidelines and algorithms for management. For irAE recognition, unfortunately, there is no current biomarker to predict who will develop an irAE, and there's no test to really confirm that it is, in fact, an irAE. Things to consider for recognition would be how the patient presents, the time from the last dose, if they've had a prior irAE, if there are any alternative causes, the severity, and the most important thing for recognition is for patients and provider education for early detection. So making sure patients know what to look out for signs and symptoms of the most common irAEs. For ruling out other causes, really looking to see if it could be due to an infection, a comorbid disease, potentially the tumor is just progressing, causing symptoms, or again, if it's in combination, different drug side effects. So here's an example of that common terminology criteria for adverse events. So as you can see, it ranges in severity from 1 to 5, mild to death, and so for the different toxicity, it goes through the grades and the severity, telling you the specifics. So for pneumonitis, the difference between grade 2 and grade 3. Grade 3 is going to require oxygen. Getting into the management of irAEs, upon initiation of treatment, we're going to be looking for prompt responses or any changes. Making sure the immune checkpoint inhibitor does get held while there is an irAE, implementing the cornerstone corticosteroids at the appropriate dose dependent on the grade, and making sure that the patient is continued on appropriate taper, escalation to other agents if it is refractory to steroids, and then for irreversible toxicities, making sure they are put on long-term replacement therapy. There are different guidelines for the management of immunotherapy-related toxicities, like the National Comprehensive Cancer Network, American Society of Clinical Oncology, and the European Society of Medical Oncology. Generally, though, these guidelines all have similar recommendations for the management of irAEs. So it's best to pick one that you are comfortable with and use that for management of irAEs. If a patient presents with a grade 1 irAE, you can continue the immune checkpoint inhibitor and then just provide symptomatic therapy. If a patient presents with a grade 2 irAE, you would initiate corticosteroids at a dose of 0.5 to 1 milligram per kilogram of prednisone or prednisone equivalents. For patients presenting with grade 3, again, holding an immune checkpoint inhibitor and treating with a higher dose of corticosteroids, so 1 to 2 milligram per kilogram of methylprednisolone per day, and then you can consider a secondary agent if the patient does not improve within 48 to 72 hours. For patients who present with a grade 4 irAE, they automatically require that the immune checkpoint inhibitor is discontinued and then to treat as a grade 3. Getting into corticosteroid dosing, so it's going to be either prednisone or methylprednisolone as a standard, and it's going to be that 0.5 milligram to 2 milligram per kilogram for 1 to 2 weeks, followed by that long taper. Depending if it's a grade 2 irAE, you can start at 0.5 milligrams per kilogram, and if they don't respond within 24 to 48 hours, you can increase the dose to the 1 milligram per kilogram. And for grade 3 events, you can start at the 1 milligram per kilogram, and if they don't respond within 48 to 72 hours, increase it again to that 2 milligram per kilogram. So they recommend continuing the steroids at that dose for around 1 to 2 weeks and then starting a long taper. There is no standard taper duration, and the optimal dose and duration of corticosteroids is not known, but the common consensus is that the taper duration should be around 6 to 8 weeks, and that there should be an even longer taper for those more severe grade 3 or 4 irAEs. For follow-up, it's just going to be monitoring for response to therapy, and then even after resolution and in the interim of the next dose, irAEs can still recur without additional immune checkpoint inhibitor exposure. So just making sure that the patient is aware to notify correct personnel if they do have an additional irAE flare. Therapy can be restarted in these patients, typically once it's been reduced to a grade 1 irAE and the patient's dosing of prednisone is less than 10 milligrams per day. Key takeaways are going to be to make sure that patients are educated on potential irAEs and the management, as they can often be a great source of information for those providers who do not typically see these types of reactions, and making sure emergency department providers know about recognition and initiation of treatment. The presentation can be subtle and conflicted, so it's always important to rule out any other cause, possible infection or progression of the disease, as well as the immune checkpoint inhibitors being used in combination. It's difficult to tell if it's mainly due to the immune checkpoint inhibitor or to the additional agent the patient is receiving. Lastly, we would like to talk about steroid-refractory irAEs. Steroid-refractory just means that the adverse effect attributed to the use of immune checkpoint inhibitors has not responded to high dose of corticosteroids within a specific time frame. A lot of the guidelines say that time frame is around 48 to 72 hours after steroid initiation, but again, different guidelines do have slightly differing recommendations. So steroid-refractory irAEs are problematic as there are no consistent guideline recommendations, as there are no robust studies in this setting. So a lot of the guidelines don't really have too great of data on immunosuppressive agents to be used in the setting of steroid-refractory irAEs. The immunosuppressive agents per the NCCN and ASCO guidelines, though, are going to be mycophenolate, rituximab, cyclophosphamide, methotrexate, tocilizumab, plasmapheresis, or TNF-alpha inhibitors. Depending on what sort of toxicity it is, they do These guidelines can give you some information about the use of these immunosuppressive agents, but you might also have to consult some case studies or case series and what other literature is out there. But the go-to for steroid-refractory irAEs would be an immunosuppressive agent. Key takeaways in steroid-refractory irAEs is to make sure that the appropriate steroid dose had been utilized, ensure the adequate duration is trialed, getting an expert consultation, as well as tailoring the second-line agent to the patient as well as the organ affected. If the patient is continued on steroids with the other immunosuppressive agent, making sure that there's a slow taper of steroid once the irAE resolves and not abruptly discontinuing therapy. Again, the importance of this talk is that there are currently 15.5 million cancer survivors in the United States, and that number is expected to exceed 20 million by the year 2026. And it's safe to believe that the number of cancer patients who will have received an immunotherapy agent as part of their therapy will also increase. So making sure that we are aware of these reactions and how to manage them. I want to thank you for your time again, and as always, if there are any questions, feel free to email me at slehman1@monument.health. Thank you and have a great day.